Namaste. My name is Dr. Elizabeth Wisniewski. Welcome to my talk today on cesarean birth, historical implications, modern day complications. Now, this work is somewhat based on my dissertation research. I defended it in 2022, and I have a PhD in depth psychology with specialization in somatic studies. I've also been a doctor of chiropractic since 2012, and I'm Webster Plus perinatal certified. So I tell my practice members everything I do is birth related because I'm also a registered somatic movement therapist, a pre and perinatal educator, as well as a registered yoga teacher 500. My focus is on holistic as well as vitalistic perinatal education and care. So welcome today, and I'm going to go through some of the historical constructs and implications of cesarean birth and kind of how we got to where we are now and different ways of viewing it so that we can not overutilize cesarean birth moving forward, but only use it when it's actually medically necessary. Now, before we quickly look at the history of cesarean birth, there's a couple of terms I want to explicitly name and call attention to. The first being that I say CB or cesarean birth. And I really try to do this when I'm presenting, in my research, in my writing, and especially in my clinical practice. I have practice members who had medically necessary cesarean births, and they have told me that it really helps them feel better about everything they went through, naming that it's still birth instead of just saying C-section. And sometimes I admit I do mess up, and I'll say C-section because it's so commonly used in our society. But as much as I can, I want to honor and have reverence for the process of birth, and cesarean birth is still birth. The other term I often use is childbearer. Now, this was strategically chosen, and I tried out so many different terms while I was doing my research, and I wanted to be really inclusive. So that is the conclusion I came to while working with a really well-known and well-respected medical, cultural, reproductive anthropologist at UT Austin, Robbie Davis Floyd. So I'm using the term childbearer when I'm talking about people who experienced cesarean births. Now let's look at some of the history and kind of where cesarean, the word, came from, what it means, and how it was popularized. Another item that's worth mentioning in brief is that a lot of my research is focused on a cross-cultural perspective. So we're looking at different countries and their CB rates, but also what's happening within the subculture of the United States, in particular, things like obstetric violence and obstetric racism. Now, these are not the focus of my talk today, but I also felt it really important to name this as I will be mentioning some of these terms and want to be really mindful of what is happening currently within our healthcare system, but especially within obstetrics as it pertains to cesarean birth. Cesarean birth, or CB, has a complicated history as well as mythology. Asclepius, the Greek god of medicine, was born through cesarean, and Thato theorized that the word cesarean comes from the Latin root word ceter, meaning to cut. Historically in the West, cesarean was reserved exclusively for childbearers who were dead or dying during childbirth. This was done in instances in which the fetus was deemed highly valuable, i.e. a male heir to the throne. Post-mortem cesarean was also prevalent during this time. This was due to laws in the Roman Empire that did not allow for the burying of the childbearer and the fetus together for religious purposes. Therefore, they had to be separated in order to be buried properly and legally. These were the ways in which cesarean was used in the West until the 1900s. There is a documented case in 1598 in Europe in which animal husbandry techniques were used in order to perform a successful CB on a childbearer who was alive. However, this was not common. It was used on those who were dead and dying. In contrast to how CB was being used in the West, Western colonizers witnessed in Uganda and other areas in Africa CB being performed on childbearers who were alive and survived the procedure. This was surprising to them as they did not think it was possible. Local botanicals were used as analgesics to ease the pain and suffering of the procedure and also to prevent infection. Infection is still a major problem with CB today. Childbearers who undergo CB have a 20 times higher risk of contracting an infection than those who vaginally deliver. The Maternal Safety Foundation says that giving birth in a hospital is actually an independent risk factor for having a CB. Next, I'm going to look at some of the stats that will further explain why this is a problem in the United States and throughout the world today. Cesarean birth, or CB, is the most commonly used obstetric procedure in the United States today. Since 2011, the U.S.'s CB rate has remained at 31.9%, and it is not expected to decrease for at least another decade. There has been a 455% increase in CB in the U.S. since World War II. To put this into some context with our neighbors, Canada's current CB rate is at 26%, and Latin America and throughout the Caribbean is at 45%, with Brazil having the highest CB rate in the Western Hemisphere at 55%. But Brazil doesn't even have the highest CB rate in the world. In places like South Africa, where there's public and private hospital systems, the South African private hospital system is averaging a 77% CB rate. These numbers are very high when in comparison with what the World Health Organization recommends. The WHO recommends that between 10 and 15% of all births should be through cesarean. There's evidence showing that rates above 10% do not decrease the risk of maternal or newborn mortality. Now, these numbers are kind of shocking. The rates throughout the world and within the United States, as well as some of the other stats that are happening. Things like Black women are dying during childbirth at 3 to 4 times the rate as white women in the United States today. And in New York City, it's at 12 times the rate. That's shocking. And why is that? Well, scholars argue that it's based on institutionalized racism. And yes, again, this talk is not about that, but it's hard to talk about cesarean birth without talking about that. I wrote 401 pages for my dissertation on cesarean birth, and this is a really short talk, so I'm trying to just give an overview. But one of the main things that happened is that the founder of modern day obstetrics and gynecology, Dr. Marion Sims, who's been lionized within the medical community for his contributions. He invented things like the speculum, but he did this at the expense of enslaved women, where he practiced on them up to 30 times to create these tools like a speculum, in which there were no analgesics. There was nothing. This was not trauma-informed. It was not consent-based, and it was really harmful. So when we look at how gynecology and obstetrics were created, it kind of makes sense why today there's still so much obstetric violence and problems. But the good news is there's so much we can do to prevent that, starting with your birth team. Now, research shows that one of the main things you can do to prevent a cascade of interventions, meaning that you have one little intervention where it's like, maybe we need some augmentation, like Pitocin, but there might be Cervidil or Cytotec used as well. Things to help you dilate, help your cervix soften and ripen. Each time another intervention is introduced, it's a cascade effect. So the thing that can actually prevent, and this is proven in the research, is having a support person, such as a birth worker, a birth keeper, also known as a birth doula. In my clinical practice, I really encourage my practice members, especially the first baby, first pregnancy, I'm like, I need you to be in therapy and I need you to have a doula. And I really push that because I've read the research and know that that's going to be really helpful. It's going to protect them. Their doula can serve as an advocate and a facilitator, putting them into different positions, having another set of hands and eyes and another heart overseeing this process, witnessing it, giving it space, but hopefully preventing unnecessary interventions that could take them down the road to unnecessary cesarean birth. Now, as I said before, not all cesarean birth is unnecessary. It's medically necessary, according to the research, 10 to 15% of the time. But we're sitting here in the United States with a cesarean rate of 31.9%. So we need to do something different. And the good news is having a support person can really help that. Now, I know these are not light topics, and we're also not getting very deep into them today because of the constraints on our time. But bringing them to awareness is a really important part of trauma-informed care and trauma-informed education. Because when we have awareness, we can make explicit our implicit biases. And implicit bias is definitely something that can lead to obstetric violence and racism. So I'm naming that as well and putting that out there in the field. And also acknowledging that so many doulas and birth workers I know talk a lot about birth work is grief work because birth is on the continuum with death. And it can be really hard. And our society wants us to be like, oh, you have a baby with 10 fingers and 10 toes and they're healthy, let's say. But that doesn't mean you as the childbearer didn't go through a lot. So I'm here to hold space and witness and acknowledge that for each one of you because it's never going to be perfect. And that's a big reason in my practice, I encourage a birth plan being turned into a birth vision. And that really includes the postpartum period. So I'll be like, what's your birth vision? And that way, there's a lot more space. And it's not like A, B, C, D. It's like, here's a landscape view of it. And here's some of my wishes and my ideal situation and scenario, but I'm also open to other things because it's never going to be perfect. Now, taking that and going back to my research, I interviewed 9 childbearers who had experienced unplanned cesarean birth between 2011 and 2021, and I used a qualitative methodology called IPA, or Interpretive Phenomenological Analysis. So part of that was they're making meaning of their birth story as they share their birth story through our series of interviews. But me as the researcher, I was making meaning of their meaning-making experience. So it's a double hermeneutic. But I was also looking at the ideography, so the images, the symbols, as well as the phenomenology, their lived experience, creating 4 main areas that emerged from the research, which I'm going to go over briefly next, which will then lead us to the last part of this talk, which is, what can we do to maybe mitigate cesarean birth that's unnecessary? And what can you do if you do experience cesarean birth? The first central theme to emerge from the research is called birth plan and choice. There are 2 subcategories that came forward as well. The first being, I had a birth plan and CB was not part of it. And the second, I like to be in control, so I did not have a plan. It was interesting as nobody that I interviewed ever expected that they would have ended up in a CB. I interviewed someone who was a doula and childbirth educator who had attended many births for over a decade. Another person had already given birth vaginally and unmedicated and had a master's in psychology. Another one is a holistic healthcare provider who practices breathwork daily and was planning on an orgasmic birth, yet they all ended up in the same place of unplanned CB. Those who chose to give up control because they like to be in control talked about how they now realized after having disrespectful and traumatic experiences that they actually have the right to choose their healthcare team, including their OB. And that was a big breakthrough for them. Second overarching theme I call the liminal space, with the liminality referring to the transport from the labor and delivery unit to the operating theater where the CB would be performed. The childbearers were being wheeled across the threshold into the unknown of motherhood. Many of them talked about what a scary time this was, and that was one of the worst parts of the entire experience. They talked about being separated from their partners temporarily, feeling cold and alone. Many of them talked about shaking violently and uncontrollably. Some of them discussed that they were convulsing, and others had allergic reactions to the medications and were never told that this may happen. The third theme is obstetric racism and disrespect. At some point during each of the interviews, themes came up such as disrespect, mistreatment, feeling like a procedure or intervention did not have true informed consent, or experiencing obstetric racism. Here are some examples from the research participants. One participant had her water broken without consent, and then at a follow-up appointment had her incision cauterized without consent. Another one's doctor spoke to her very disrespectfully, and she recounted that she did not believe he would have spoken to her that way if she had straight hair and not her type 4 racialized hair. Another one talked about being first generation Mexican American and how she never felt like she could have a voice, and she witnessed how her parents were treated. So this played out even in the hospital, where she wasn't asking for any of her needs to be met. Holding space for these stories was humbling and a true honor, as telling your birth story is deeply important to the process. This theme in particular brought together many aspects of my literature review, from Begley and Peruzzi, as well as DiMatteo and so many authors who speak about and write about disrespect and mistreatment, to the history of obstetrics itself, with the sins of Dr. Marion Sims, the founder of modern-day obstetrics and gynecology. The final theme that emerged is called being on the verge of vaginal delivery. When I started my dissertation journey, I was curious why so many childbearers were ending up in an unplanned CB. While 6 of the 9 participants had actually been at 9 to 10 centimeters dilation before the plan was changed to do a CB instead of vaginal delivery. They were told, your pelvis is not the right size, it's too small, the baby's too big, your bones are not the right shape, they're not going to open anymore, or some sort of combination. The blame and shame was being put on the birthing body rather than maybe the birthing institution and culture. This only brought up more questions for me as the researcher, though. Would this look different if they were birthing in a different model, a humanized or holistic versus a technocratic model? Would it look different if they had more support, such as a doula or midwife or more integrative healthcare? My curiosity only grows. The other interesting part of this was they talked about their healing process. And not only did they have to heal from major abdominal surgery of the CB, but they also had to heal vaginally, which was really challenging for them. Now that you have an idea of some of my research findings, here are some practical implications for both practice and just in life, if you've had kids or you're planning on in the future. Stepping away from using the term birth plan, I find this really helpful with my practice members. You can use birth vision or anything else that comes to you and make sure it includes preconception if you're starting at that point, definitely prenatal. What kind of care are you going to have? Who's on your team? I always ask that. And I want to really empower individuals to know that there's options. So I'll say, who's your midwife or OB? And I say it in that order, just like that, because I just want to plant the seeds that there's always other options. Even if they're never going to use a midwife, I want them to know, like, hey, everything's accepted here and there's no judgment. So things like birth vision also need to include postpartum. Being in contact, if you're a provider, with an IBCLC, other lactation consultants and providers, cranial sacral therapist, acupuncturist, All these people are good friends of mine in my community. We work together, we hang out, and it's nice as a birth worker to be friends with other birth workers because we all kind of have wild schedules. Another recommendation I give all my practice members, and it does not matter to me whether you birth your child vaginally or through cesarean, is to work with a pelvic floor physical therapist. This is vitally important. I send out information on how to massage around your scar so that we're preventing adhesions, because that could impact your digestion and really have huge implications on your fascia throughout your entire body for the rest of your lifetime. So I want everybody checked. And I tell my patients, I'm like, hey, I don't know if you need to do a reverse Kegel or you need to do them in a different position. I'm going to stay in my lane, and I really want you to go to a pelvic floor PT. And then if they're like, oh, I had a cesarean, I'm like, that's okay. You still carried a baby. Things still change. And especially if it ended up being an emergency cesarean and you had been in labor, it's a lot of healing that has to take place. So I really, really encourage that for all individuals. Find a good pelvic floor PT in your area. Another important thing is to work on your mindset. The research shows that if you're kind of, let's say, willy-nilly and open, but in a way that you're going to give up power. So it's not just being like open-minded to like, I'm going to be in that flow. That's a good place to be. But being in a place like, oh, I'm just going to listen, like whatever the doctor says, there's a higher risk of that cascade of interventions that we talked about earlier. So that's why having a birth vision and then a support person like a doula is so important. Like I talked about at the beginning, that's going to prevent that cascade of intervention. And knowing what your boundaries are of, it's really important for me to keep the cord attached for a longer period of time. Or I'd really like to try cord burning, which comes out of some different traditions, rather than cutting the cord. Having those clear boundaries and then having somebody else help advocate for those is important for prevention of things that might lead to mistreatment, disrespect, obstetric violence, cesarean birth that's unnecessary, all of those things above. Another area that came out of my research is that most of my participants were like, I didn't pay attention during my birth prep class that I took at the hospital or wherever when they were talking about cesarean. So I try to highlight that with my own practice members and go over some of the things that came up from my research of, you may not be told this or you may not remember being told this, but oftentimes you're going to shiver and you're not going to be able to control it. And yeah, they're going to put warm blankets on you, but just know that can be a really common response to all the medications and everything that's happening. So you might be shaking. You might feel like you're convulsing. Because for me as a provider, consent is really important and that's ongoing. So I want them to know ahead of time, even though I'm obviously not performing the cesarean birth, I feel like it's my job as a provider to let them know these different things that could happen, but to say it in a really trauma-informed way, not to freak people out, but just to be like, this is something that could come up, and I want you to be aware so that you know you're safe and that it's normal. Another part of that came up that I mentioned was that liminal space and being separated from a partner. This happens, when they have to scrub in, all that kind of thing, get ready, and there's that separation, and you can make people feel really lonely. So just knowing like you might be separated, try to, if there's a nurse there that you feel a connection with, just let them know like you're scared, please stay with me for this moment or whatever it is, to name it if you can. But again, having that information is a great way to prevent trauma or at least to mitigate some of it. So those are some of the things I really prep my practice members on so that we don't have to process those parts of the trauma later on. Finally, I really want to emphasize that if you ended up in a cesarean birth that was unplanned, unwanted, maybe unnecessary, you did not do anything wrong. It's not for a lack of planning. It's not because your hips were too small, your baby was too big, your body couldn't do it. Sometimes cesarean birth needs to happen and it can be life-saving, and that's amazing. And that is so powerful. And it doesn't mean you didn't give birth. You still did. One of my favorite article titles I cited in my dissertation was, "Pizzas are delivered, babies are born." So let that land for a moment. Pizzas are delivered, babies are born. So no matter the mode of delivery, you still birth this being into the world, and that is beautiful, that is powerful, and that is potent. That is empowering.